Recanalization of the bile duct using percutaneous and endoscopic methods following iatrogenic injury. The primary author is Arjun Sondhi. No funding was required for creation of this video case report. Ryan Law is a consultant for Olympus America. All other authors have no relevant conflicts of interest. Our patient is an 87-year-old man, status post a hand-assisted laparoscopic cholecystectomy 4 weeks prior, who presented for treatment of a bile leak due to an iatrogenic common bile duct injury. The subhepatic drain placed at the time of surgery recently had cessation of bile output. Cross-sectional imaging revealed a 5 cm subhepatic debris-filled collection. An ERCP was attempted locally, but was unsuccessful due to the abrupt cutoff at the common hepatic duct and the inability to access the intrahepatic bile ducts. The patient was then referred to our institution for management. Review of cross-sectional imaging demonstrated a collection in the gallbladder fossa which clearly contained debris and air. The common bile duct could be visualized to the level of surgical clip placement. The common hepatic duct was unable to be visualized. There was no evidence of intrahepatic biliary ductal dilation. Due to this constellation of findings, the patient was referred to interventional radiology for placement of a right-sided percutaneous transhepatic biliary drain which terminated in the subhepatic space adjacent to the bile duct injury. A multidisciplinary approach was utilized to achieve biliary recanalization in this patient. An angled guide wire was manipulated past the site of clip obstruction and coiled into the subhepatic collection. Contrast injection using an inflated occlusion balloon confirmed placement within the subhepatic collection. The tract was dilated using a 543 catheter followed by a 6 mm balloon dilator. Digital single operator cholangioscope was advanced over a guide wire through the common bile duct and across the site of bile duct transection. We were able to access the subhepatic fluid collection where the percutaneous locking loop catheter could be visualized. The cavity was explored using the cholangioscope, and a side hole was identified on the looped portion of the percutaneous biliary drain. With difficulty using an angled tipped guide wire, we were able to access a side hole of the percutaneous biliary drain. The guide wire was advanced, traversing the looped portion of the percutaneous drain and exiting distally into the subhepatic fluid collection. A safety wire was placed through the percutaneous drain and coiled in the subhepatic collection. The percutaneous drain was then removed, carrying with it the endoscopically placed guide wire. The endoscopically placed wire was then brought through the skin site to achieve maximal mechanical advantage for subsequent biliary interventions. An occlusion cholangiogram performed near the area of the presumed bifurcation demonstrated filling of both the right and left hepatic ducts. A 10 mm by 10 cm non-foreshortening, fully covered self-expandable biliary stent was placed into the bile duct to traverse the site of transection. The stent was placed such that the proximal aspect of the stent was in the right main hepatic duct, and the distal aspect was left completely intraductal in the distal common bile duct. Contrast from both the right and left hepatic ducts drained rapidly. As a mechanism to secure stent placement, an 8.5 French locking loop internal-external biliary drain was placed through the lumen of the self-expandable metal stent. The drain was advanced into and secured within the duodenal lumen. Repeat percutaneous cholangiogram performed 48 hours later shows no significant dilation of the left hepatic duct with rapid contrast drainage. Our patient was discharged 3 days after his recanalization procedure. The internal-external biliary drain was removed 4 weeks later. At present, he is back to all baseline activities, including daily exercise. His liver chemistries remain within normal limits, with no concern for biliary obstruction or cholangitis. He will be managed expectantly with no plans for removal of his fully covered metal biliary stent due to his age, medical comorbidities, and the uncertain risk of bile duct stricturing following stent removal. In this case, we were able to avoid surgical intervention, which carried a substantial level of morbidity and mortality. Furthermore, we were able to avoid long-term percutaneous drainage, which was also felt to be an undesirable outcome for this patient. Recanalization of the biliary tree using a multidisciplinary approach was technically and clinically successful for our patient. Iatrogenic common bile duct injuries occur rarely but often require surgical intervention. Our case demonstrates that non-surgical intervention may be feasible in select cases to achieve recanalization of the bile duct.